Welcome, welcome everybody. You're at the Silver Hill Hospital Grand Rounds, and we'll get started in just a moment. All right, welcome everybody. Hello, I'm Dr. Jeff Katzman. I'm the Director of Education and the Silver Hill Academy for Research and Education here at Silver Hill Hospital. And what an honor to be doing this grand rounds in honor of Nurses Week. And I'm joined today with Dr. Immaculate Khan, who's our Chief Nursing Officer here at Silver Hill. Thank you, Immaculate, for being here today, this special week with me. We're delighted to have you join us. Offer a special warm welcome to all our nurse attendees out there in recognition of Nurses Week, and we send really our greatest appreciation and thanks for everything that you do. Today, we're privileged to welcome Dr. Joyce Shea, who will be presenting on the topic of integrated behavioral health care, models and outcomes of care. A bit of housekeeping to start us off. Our next Grand Rounds takes place on May 14th with Dr. Christine Miller, who will talk to us on the topic of internet addiction, which may hold broad appeal to lots of people. So spread the word about that. Thank you in advance. And to see all of our Silver Hill Share events, our grand rounds, and other presentations, please visit silverhillhospital.org/calendar. Back to today's lecture. Your questions remain an important part of our grand rounds. Dr. Khan and I will moderate a Q&A discussion with Dr. Shea at the end of her lecture. And this is a great opportunity to put forward questions and comments, which you can submit anytime during the lecture by using the Q&A link. If you'd like CME or CEU credits today, please complete the evaluation survey that will automatically show in your browser when we end the webinar. A link to the survey will also be emailed to all participants tomorrow. Note that this email will be a Zoom email coming from SHH Events. The email will also contain a link to the recording and slide presentation. So that all participants have enough time to complete the survey, it will remain open to the end of day on Friday, and certificates will then be emailed within the week. Any questions? Please contact us at shhevents@silverhillhospital.org. Finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME defined commercial interest, and Dr. Shea will show a slide with her disclosures. Now it is my deepest honor to turn this talk today over to Dr. Immaculate Khan, who is our wonderful Chief Nursing Officer here at Silver Hill Hospital. Again, Immaculate, thank you for joining me, and I'm going to pass the baton to you.
Thank you so much, and happy Nurses Week to all our nurses who are online with us today. It is really a tremendous pleasure and honor for me to introduce our guest speaker today, Dr. Joyce Shea. Dr. Shea is a board-certified advanced practice psychiatric nurse specializing in integrated behavioral and physical health care. She has presented her work both nationally and internationally, as well as published in many peer-reviewed journals. She recently retired from her position as Associate Dean for Graduate Studies at Fairfield University's Egan School of Nursing and Health Studies, having previously served for 5 years as secretary on the board of directors for the American Psychiatric Nurses Association. She stepped into the role of president for this premier psychiatric nursing organization as of October 2024. Dr. Shea also recently co-chaired the National Task Force for revising the scope and standards of psychiatric nursing practice and has received over $6 million in HRSA funding, with the most recent grant focusing on telehealth care and interprofessional practice. Dr. Shea was inducted as a fellow in the American Academy of Nursing in 2022. So I am just extremely honored, Dr. Shea, that you are here with us today. And I will now pass the baton over to you. Thank you again for being with us today. And thank you all for joining us.
Thank you so much for that very kind and warm introduction. I appreciate it very much. I'm going to share the slides and then start with my presentation. Let's hope this works. Share and slideshow. Okay. Is that working for everyone? Yes. Okay. I assume you'll tell me if it's not. Again, my thanks to Dr. Khan, to Dr. Katzman, who I initially spoke to about this, to Ann Romano and Laura Magliola for helping with all the behind the scenes details that need to get put together for this to be a success. I do want to give a shout out, thanks also to a longtime colleague that I hope is probably on the call, Dr. Deb Ostreicher. I've known her for a long time from various positions that she's worked in, and I thank her for apparently, I think she put my name forward for this. And I'm really delighted to be part of this presentation that is falling on Nurses Week. It's kind of uniquely special to me to recognize this work that psych mental health nurses do on the week that others are recognizing the work you all do. In terms of the topic, I've had a very long-standing interest in integrated behavioral health, as you've heard in the introduction. Different terminology was used over the years that I've been interested in this, certainly over the last, say, 15 years or so. And I'm always consistently hopeful that this particular model of care, the integrated care model, with its positive outcomes, will be helpful, particularly for those who have severe mental illness, the nearest and dearest to my heart in that sense. Forgot to turn on the timer as always, so we'll put that on quick. Sorry. In terms of my disclosures, I have no relevant financial relationships to disclose in regard to this presentation. In addition, I do want to mention that although I'm serving currently as president of the American Psychiatric Nurses Association, the content here, the opinions that I'll be offering are mine as an independent clinician, as a faculty member over the years. I'm not speaking for or particularly representing the views of APNA through this presentation. That being said, APNA, in fact, has a position paper that states, and I'll quote, integrated care models should be utilized to improve health equity by collaboratively and comprehensively addressing the complex physical, mental, and sociocultural needs of patients to decrease morbidity and mortality. It's a very clear message on that position paper. It's available to any of the public if you are so interested in going to the American Psychiatric Nurses Association website. But it's definitely a shared passion. These are the educational objectives for today. I'm not going to read them to you. I will say that I'll give you a bit of a introduction to how this is going to particularly start out and what I'll be doing as I work our way through. I'm going to start with a very brief summary of 3 separate cases. These are cases that are not real people. I want to make sure that you're aware of that now. Some of them are a conglomerate of patients that I've known or some of my colleagues had known. The first 2 were actually created for simulations that I used in my work with both family nurse practitioner and psych mental health nurse practitioner students at Fairfield. And I want you to try to keep these cases in mind as I move through. So case one is a 37-year-old married white male, Army veteran, presents to his primary care office. And I will kind of particularly point out each of these cases presents in a different setting, which is important to keep in mind for integrated care. His chief complaint, I'm not sleeping. I fell off a ladder last week. My back is killing me, and I'm running out of sleep and pain medication. His presenting symptoms, he gives an assessment of a 9 out of 10 currently in terms of a level of pain. He takes the oxycodone 20 milligram doses every 4 hours, says he needs that, and even that's not totally touching it. He also uses more Xanax that then has been prescribed to address sleep issues, so he therefore has used that up more quickly than it would have ordinarily covered him. The current meds, oxycodone 20 milligrams every 4 to 6 hours as needed for pain, Xanax 2 to 4 milligrams at bedtime for sleep. And as I mentioned, he's taking the maximum, if not a little more. It had been prescribed starting before the recent fall, but he's definitely needing it now. In terms of past medical history, he sustained a closed head injury from an IED explosion 10 years ago when he served in the military. He also had a number of back injuries that also occurred while he was in the service. From a social history perspective, he is married with 2 young children. He works as a cook at the local diner. He had recent contact with police over a domestic dispute, and he is scheduled for a court date in 2 weeks related to that. So that's case one. Case two is a 48-year-old divorced white female who presents to the behavioral health clinic. Her chief complaint at the time, I don't know what's going on. I've been feeling more depressed and anxious for the past month. I'm really cranky with everyone. I can't sleep, but I feel exhausted. In terms of history of the present illness, she has about the 1 month history of feeling increasingly depressed, anxious, talks about being jumpy, irritable, has difficulty sleeping and increasing fatigue. She reports no known precipitants and no previous psych history. Her current meds are mostly supplements, as you can see, glucosamine, chondroitin, biotin, vitamin B12, and vitamin D3. Her past medical history is positive for Raynaud's disease, and she's post-hysterectomy. In terms of family history, her mother had Hashimoto's thyroiditis, and her father had hypertension. Socially, she's divorced. She had no children. She has one brother who's married and living in another state. And then the last case, 44-year-old married white female who presents to the oncology clinic. Her chief complaint, I was always a crier. Her history of present illness, she had a 6-month history of not sleeping well. She has trouble falling asleep, wakes up often throughout the night, feels very tired, no energy. Appetite is decreased. She has tried marijuana with some effect for this, no other drug use. She reports some anxiety, some decrease in concentration, said her mood varies day to day, but she currently denies any sense of hopelessness or suicidal ideation. She had previously been prescribed Ativan. We don't have the dosage right then. She was prescribed Zoloft 25 milligrams daily by her primary care provider a week ago. She takes it at night because she says it makes her sleepy a little bit. Past medical history, this woman was diagnosed with metastatic pancreatic adenocarcinoma in May of 23, and about 4 months later, she was also diagnosed with type 2 diabetes. Socially, she's married, lives with her husband and a 20-year-old son. She has also a 28-year-old son and 2 grandchildren who live in another state. She is formerly an LPN, and she's now on Social Security disability. So when you hear these, go back. When you hear these cases, what strikes you as things they might have in common? Well, first of all, as I had mentioned, they could present in any case, the primary care clinic, the mental health care, or in the last case, in their oncology clinic where they're getting ongoing treatment. What initially appears to be simple or straightforward, I'm having trouble sleeping, may in fact not be, or this pain, or I need a refill of meds. All of these patients have definitely got a mixture of physical and behavioral health issues or concerns, even if they don't see it that way for themselves. In fact, often when you have cases like this, if they've shown up for physical health care and you begin to address concerns in the mental health arena, they can get upset or at very least, concerned. Well, why are you asking me this? I'm not crazy, quote unquote. And to explain to them the links between physical and mental health is critical to be able to do that. And I think the treatment outcomes would always benefit from some level of collaboration between the medical and the psychiatric care providers. I want to spend some time talking about what I consider the origins of integrated care. What we call integrated care now has in fact been around, believe it or not, nearly 50 years at this point, which I find hard to believe since that goes back to before I actually had just started in this field. But we know that there's a long history of separating out the physical and mental health issues, separating psych and non-psych patients, and in fact, separating psychiatric specialists from other healthcare providers. That's been there. And that started way back with Descartes and the Cartesian dualism, that you either had something affecting your physical health realm or your mental health realm, and never the two shall meet. And that persisted for a very long time, both in terms of patients presenting or how they talked to you. It depended on who they were speaking with, what symptoms they might report. Then in the later 1970s, the George Engel came up with this, no longer sounding so dramatic, but the biopsychosocial theory, which really addressed the fact that there were always multiple causes, multiple factors that resulted in disease or symptoms. And that's when it began to become mainstream medicine there. I will give a plug here for nursing, since this is Nursing Week. Traditional nursing assessment has always involved a very holistic view of the patient, evaluating the patient's physical, psychological, social, and spiritual status. All of those have always been there. I also, when I was thinking about this, it became clear that COVID-19 was also a very large factor in continuing to break down some of these walls and some of these separations there. We also, over the years, have gathered an awful lot of data that really shows that individuals with behavioral health conditions are also likely to have physical health issues. Sometimes they are comorbidities, they're happening together. Sometimes there's a sequential thing, depression then leads to some other health issue. People with severe mental illness have really been the ones that have the poorest health outcomes when compared to the general population, or even those that have what would be considered less serious mental illness. Initially, the estimates indicated that people with severe mental illness died about 25 years earlier than those in the general population. More recent estimates are more like 12 to 15 years earlier, but that's still a significant difference. So the fact that they often have both and that it leads to early death is significant. There's also a lot of stigma. None of us need to be told this, that there's a lot of stigma related to having a psychiatric disorder, psychiatric illness. If we send patients to a facility that exclusively offers mental health care, there's probably a reduced chance that they're going to actually seek treatment. If they initially showed up, for example, to their primary care provider, who is the one that offers a lot of initial treatment, sometimes the only treatment that people with mental health conditions have. And then they get to a point where it's a little more complex. They need some help dealing with it. They might or might not follow the recommendations. And the estimate in terms of people that are followed by their primary care, even a third of those with serious mental illness, severe mental illness, received care in those primary care settings. There were also a lot of policy changes. I say the early 2000s, it really started like 1999 and then into the 2000s, that set the bar, that really indicated that it was important to begin to do a better job of integrating physical and mental health care services. And the goal was for healthcare organizations to enhance the number of mental health care providers that are in primary care settings. Although it was put out there then, it took quite a while to really become more commonly found. It was much more the exception than the rule. About the same time, although a little bit later, they figured out that there was also a need for what sometimes has been called reverse integrated care or bidirectional care. And that's where primary care providers became embedded in community-based mental health care centers. In other words, there was a lot of people, particularly those with severe mental illness, whose main link to healthcare was through their mental health care location. And they believed then, and it's part of one of the models that are most active now, that this would be a reason why you would put primary care providers in those systems of care. In spite of those policy changes, though, there were a lot of reasons for laggards in terms of adopting this approach. One issue seriously slowed down the move towards this was the fact that coverage, whether it be through Medicare, Medicaid, or private insurance, was often not there or not provided if a patient was seen on the same day for both physical and mental health care. It would get denied. They would only pay for one and not the other. Obviously, a big deterrent for any organization that decides to offer this, because to ask the patient to come back another day for the other type of care also didn't make sense and also decreased the likelihood that they would, in fact, show up for that. And then in 2013, again, at the federal level, SAMHSA and HRSA created the Center for Integrated Health Solutions, and they were the first ones to offer a solid framework for what this might look like. Boots on the ground in the community-based settings, what kind of various levels of care, of integrated care you might have. And I do have a later slide that will show you just a view of what those levels look like and some of the accompanying structures. And then the last part that I wanted to address as part of the origins, if you will, there were a number of additional movements or concepts that have really facilitated integrated care being more widely adopted. And they include things like whole person care. While many of you may have heard of this now, when it was first out there, a lot of folks didn't understand what this meant, but it should, again, not be unfamiliar, particularly to nurses who, again, are educated and prepared to assess a patient holistically. But that became a goal for many organizations to say we are addressing the needs of our customers using a whole person care approach. The second, which I think has made an even bigger difference, was this person-centered care. A lot of this came along the same time that consumer rights movement was beginning to take off. Individuals who objected to being seen, just unidimensionally, I am a diabetic, I am this. Or they objected to having to go to multiple providers or locations to get their needs met, or to go to providers who never seem to communicate with each other. My guess is that many of us have had that experience if you went to more than one provider, a number of specialists, that your primary care provider may or may not know all of the folks you're going to, may or may not have discussions with or communications from those specialists. And most likely the specialists never talked to one another. And that was very frustrating to the people that were in fact receiving care or trying to get the care from that. So the person-centered care came about that it was meant to address all the needs that from the person's perspective were important, were a priority for him or her. And this also involved the notion of shared decision making, that patients should be able to have a voice in what is what are the things that are most important to address in the plan of care, how those are going to be addressed, are they going to be something that is acceptable to them? Again, many of us may have had experiences with people who sit there as the main provider, or the team sits with them and describes, this is the care plan that we've come up with, and they nod and they leave, and they don't necessarily follow anything that was put down. And part of it is often comes down to whether or not they were involved in making those decisions to begin with, or in some cases their families, were they part of that? And now person-centered care is also part of quality care initiatives. Um, Joint Commission requires evidence of, person-centered care for accreditation purposes, for making sure that the needs are being addressed. And the last one is more recent, but definitely because of COVID-19 is obviously come front and center for psych mental health care. And that's the whole approach of virtual care. A lot of resistance early on to this notion that you could see a patient online and do the assessment and come up with a plan of care uh, virtually, as well as seeing them in person. Um, this telehealth care, there's other version or other aspects to virtual care, but I'll focus in particularly on telehealth care, clearly came to the forefront during COVID-19. Um, we were, we had no other way to kind of keep track of um, seeing our patients on a regular basis, finding out how they were doing. Did they need more medications? Did they need other resources? What was happening with them? And there was serious safety concerns. So telehealth became a very viable alternative, particularly in states like Connecticut that prior to COVID-19 had not used telehealth very much at all, because telehealth was earmarked for those places that had a lot of rural areas where people lived miles from the local hospital or clinic. And this was a way for them to be able to receive care, ongoing care, follow-up care. But in Connecticut, as you know, a very small state, there's a couple in the northeast part and a couple in the northwestern part of the state that are considered rural areas, but not really. For the most part, people in Connecticut are very close to a hospital or a clinic. So once COVID happened, we became introduced to that, and we'll just leave it at that it certainly is still a part of what we offer, particularly in mental health care. So I'm going to offer this as the current and very complete definition of integrated behavioral health care. And this is from the Agency for Healthcare Research and Quality. According to them, integrated behavioral health involves a practice team, a team that includes primary care and behavioral health clinicians working together with patients and families. Remember what I said about the patient-centered care and shared decision-making. Using a systematic and cost-effective approach, that's the goal, I would say, not always the reality, to provide patient-centered care for a defined population. That population could be women 18 to 25 pregnant with their first child and exhibiting signs of depression or at risk for depression. It could be clients that are at risk, chronic pain patients that are at risk for substance use. There's a whole way of defining populations. It could be those with severe mental illness, but that's not the only one. The care, however, may address all of these mental health and substance use conditions, health behaviors, life stressors and crises, stress-related physical symptoms, and ineffective patterns of healthcare utilization. So this whole package is considered to be something that should be addressed if the organization, in fact, is saying that they're an integrated behavioral health care one. And I will say that most of the work that's been done in integrated care has focused on community-based settings that link primary care and mental health care. However, there are also studies, I wasn't as aware of many of these until I started to look at the literature for this, but there are definitely studies that have addressed integrated care in acute care settings, although it's more commonly focused on those outpatient. I can share some info if we have time at the end on what some of this literature, there's a systematic review of it, and I can give you some pointers from there if people have questions at the end, if we have time. I'm going to give you the goals, and I'm merging them with outcomes because they were both the aims or the goals of setting these kinds of systems up, and they are also the outcomes which some of which would be measured in an integrated behavioral health care system that you're trying to integrate with varying degrees of success. We'll leave it at that. When I talk next about some specific models, current models of integrated behavioral health care, they, for the most part, didn't necessarily address each of these when you get either randomized controlled trials or systematic reviews. It's difficult to capture all of this, but these are kind of broadly based goals. If you have this system, it is meant to have the impact on increasing access to care. As I mentioned, if people are located at the same facility or if they are very tightly connected, it's a higher likelihood that the person can access the care they need when they need it. It decreases the stigma attached to that, and therefore they are more likely to access the care and to follow through. The decreased costs is certainly an aspirational goal. In many cases, it hasn't always worked out that way, and that depends on the population. As I mentioned, it can be geared to meeting the needs of specific populations. So when you look at the literature on how effective has this model been in reducing costs, it depends. So people, with severe mental illness, while it has definitely impacted some of the other goals here, hasn't always been as effective, at least in the earlier stages, as they had hoped to decrease costs. For example, decrease trips to the emergency room or decrease hospitalizations. In fact, when physical health care is added to a mental health care clinic, that sometimes led to some greater costs related to the now identified physical health issues. So it kind of was a double-edged sword, if you will. But longer term, I still believe that it could, if it's implemented correctly, could have an impact on decreasing costs overall. It definitely, for both patients and even providers, showed an increased satisfaction with care. Um, it- People were just generally happier that their needs that they identified were being met in ways that were more acceptable to them. It increased, therefore, their assessment of the quality of care. Um, and in some studies, it did show some increased quality of life, but that's very difficult, to measure. There's numbers of tools. If you've ever looked at this, there's a number of tools. Basically, the best measurement of quality of life is simply asking one question: how would you rate the current quality of your life on like a 1 to 10 perspective, whatever it is? And that gives you as valid and reliable a measurement, as anything else. All right. So initial models of integrated behavioral health, I would say up through, it's like 2015, really we're very specific about a structural level in which physical and mental health services could be offered in an organization. Um, there was the Center for Integrated Health Solutions that I mentioned earlier was the first one that kind of put it together in this way, identifying three key ways in which those physical and mental health care services could be offered. The first being a level called coordinated, where there were community mental health and primary care partners that had some kind of formal affiliation, but physically they were separate. They did far more work on communication between them. The next step up, co-located, meant that those services were delivered in the same location, but not necessarily the same offices. So you might have a large building, a community health center, and you're on the first floor over here for physical health care, and you're upstairs in the back for mental health care if that was needed. But there was physical proximity. They didn't have to go to an entirely different spot. It Aside from the issues initially uncovering seeing someone for both physical and mental health care issues the same day, it was at least possible. And then the last was integrated. And this is when those services are delivered in the same space within the same facility. And many of these sharing at least some of the practice space. So envision, if you will, an open area with computers around the side, um, where providers are maybe seeing that patient for their physical health care. It's a primary care provider. And then across the room is the mental health care provider that they would like to refer this patient to or have a discussion with. Could be something called a warm handoff, where literally they talk to each other at that moment. I have a concern about Joey here. Here's what's going on. Would you be able, give me some suggestions of how to deal with this, or would you be able to see him, speak with him, that type of thing. And the key element in this is practice change, that it really is offering things in a very new way, and seeing it done in a way that has never been done before. For example, a shared electronic health record, and I'll talk more about that. The last one, integrated model, is done in Connecticut at CHC Incorporated. I had students go there. I had students who graduated and ended up working there, and then other students that experienced that as part of my grant that I used. This is that community Center for Integrated Health Solutions that I told you had been developed between SAMHSA and HRSA. And you'll see at the top those three levels: coordinated, co-located, and integrated. Then they further broken them down, each of them into two levels. And depending on what you were looking at, whether it was the services provided, how the care providers actually work together, how was the financial arrangements made, all of that stuff was included. This is just one of the sheets. I actually used this, it came out in 2013, and I had used this as a framework for my first HRSA grant that focused specifically on integrated care. And it was a curriculum that was meant to improve these skills in our nurse practitioner students. So now I'm going to talk a little bit about three specific current models that have the most data or studies done of them and are the most commonly recognized ways. And you might say with some of these that it seems like it's very they're very similar in some ways, but there are subtle differences, subtle distinctions, and there is definitely a distinction made depending on the population that you are meaning to provide care to. So the first of these is called the Primary Care Behavioral Health Model, or the PCBH. I'm going to drive you crazy with all these acronyms. This is a model that is described as a team-based primary care approach to managing behavioral health problems and psychosocially influenced health conditions. So the focus is on primary care. Within that primary care team, you have individuals embedded who can help with associated or identified behavioral health problems, or things that are just more behaviorally oriented that are influencing their current health condition. So the main goal is to enhance that primary care team ability to, first of all, identify through screenings and initial assessments, and then how to treat mental health issues that are commonly seen in primary care settings. The person embedded is called a behavioral health consultant, or BHC, into that primary care team. They're kind of seen as an extension of the primary care provider. They operate, and this is important, as a generalist. They see patients of all ages with various issues, mental health and physical, and they also have a role in providing education for both staff and patients. Their work is often to do the quick consults, the warm handoff that I mentioned before, briefly in treatment. They may or may not be the ones who continue on a longer term basis to see the person with a mental health condition, but they can provide feedback to the primary care person who may be the one who manages that. There's two more models that I'm going to cover. Oh, sorry. First, an example of the PCBH model. And this is referred to in a lot of the literature. Cherokee Health Systems is down in Tennessee, just around Knoxville area. And they have, as identified in the model, they have primary care physicians and behavioral health specialists that work collaboratively as a multidisciplinary team. These kinds of models really require high levels of cooperation and respect amongst the team members. It is not an issue where the primary care specialist is going to say, okay, you deal with this, anything related to their depression, you got to take care of. I don't want to have anything more to do it. It is really a collaboration where both members of the team come up with a plan, work it out with the patient and or the family if that's appropriate. And there's just a really high level of trust among them. The things that make that work, and this is based on the write-ups that Cherokee Health System has about their PCBH system. They do a tremendous amount of communication from the very beginning to the shared electronic health record, ongoing primary care team meetings. They share patient information, and they jointly develop the treatment plans, as I mentioned. The sharing of the information does refer to the electronic health record. And the thing I want to mention here is behavioral health specialists are sometimes the more resistant one to that particular aspect of it than the primary care people. And that's because over time, we had viewed our notes on an interaction with a patient, our assessment, our ongoing therapy sessions as very privileged and just should be available to the person delivering that care or to uh, the patient themselves, perhaps another consultant if they needed to bring them in. And they were concerned that sharing all of those was overstepping the boundaries. And in many of these systems, what has happened is not all therapy notes are necessarily open for anyone on the team to access, but um, assessments, description of main issues, how the treatment is progressing, those kind of notes to update everyone on the team would be shared, but not, again, necessarily on the patient, more personal information. The emphasis is also on screenings in these things. So you would screen for things like depression, anxiety, substance use. We know that early identification of these disorders really sets the stage for better outcomes, as opposed to not addressing it, not paying attention, not having the patient actually seen in any mental health care setting. So the screens might include PHQ, which is Patient Health Questionnaire, PHQ-2 or PHQ-9, focuses on assessing for depression symptoms. The GAD-7 is the tool that could be used to get a sense of anxiety symptoms. The audit tool for alcohol use, and going along with the depression screen, these organizations would always have to have available some kind of suicidality assessment. For example, the Columbia Suicide Severity Screening Tool. Uh, and that both the primary care and the behavioral health staff needed to get more comfortable with collecting that information, helping people to fill it out, so on and so forth. So this is where they say in Cherokee that they offer the integrated care in primary care clinics, community health centers, as well as some specialty clinics. And the emphasis being on preventive care, early intervention, ongoing support for chronic medical conditions, mental health disorders, substance use issues, and any psychosocial challenges. So that would include housing issues, financial stress, that type of thing as well. The second model I wanted to mention here is something called the collaborative care model. And it's usually capital C, lowercase o, capital C, capital M, but this particular font wouldn't let me have a lowercase o there in the title, but that's how it is, and it's called the collaborative care model. Another systematic approach that integrates mental health services into primary care settings. This approach, the team is led by the primary care provider. And again, it includes a specialist, a behavioral health care manager, who has a background in mental health care, not necessarily a psychiatrist here. They might be a social worker, they might be a psychologist, they might be, some other, a counselor themselves, as well as there'll be a consulting psychiatrist or in some cases a psych mental health nurse practitioner. In this system, the primary care provider initiates a patient referral to the behavioral health care manager. That person performs an initial evaluation and then takes that information and shares it with the consulting psychiatrist or psych NP. And then they together come up with a treatment plan, which the behavioral health care manager shares with the primary care provider. The primary care provider reviews it and implements it. Again, sometimes they would be the ones who could continue to care for that person if there's, say, low levels of depression or anxiety, and other times they might coordinate the care with the psychiatrist or the psych NP. The other important thing is this behavioral health care manager in this system uses what they call a registry to track all the patients and prioritize regular reviews. So they would add Joyce Shea's name to this registry of some of the basic information, not all things, but just when they started, what were the primary issues, and what was done, what were the recommendations. And that would set up a way of triggering, we need an updated status on what is happening with this patient. Is the person showing up for treatment? Is the person responding well to treatment? Do we need to have more involvement of the consultant, and so on and so forth? This is a model that is particularly highlighted by the American Psychiatric Association, and I'm borrowing the graphic they have on their website to kind of put out there as this is exactly what I just explained. Primary care provider at the top, heading the team, works with the patient, identifies an issue, involves the behavioral health care manager who sees the patient for that initial review, shares the findings with the psychiatric consultant, comes up with a plan that goes back to the primary care provider, and the behavioral health care manager also adds the patient to the registry for follow-up. A good example of this type of model is something called the mom care interventions. It was integrated into several women's health settings in the Seattle, Washington area. The targeted population, remember, it's very important to understand the population you're going to use this approach, this model with. This was for socioeconomically disadvantaged women who were at risk for perinatal depression. And what they found when they collected the data over an 18-month period, that the people in the program compared to those receiving standard care through the public health maternity support service had significant improvements in what they reported as the quality of their care, in the depression severity, the level of severity of their depression, as well as remission rates. So it worked well for most of the people in that program and worked better than the standard of care. The final model that I'm going to share with you is something called the Patient-Centered Medical Home, or PCMH. And I'm sorry, it's an acronym that's very similar to the Primary Care Behavioral Health, or PCBH. This is the PCMH. The medical home models have been around for a little while, but this patient-centered aspect to it, as well as its use for, in particular, the population of people with severe mental illness, is a little newer, and has ended up meeting with quite a bit of success if it's done well. And it essentially, the goal or the aim is to transform how primary care is organized and delivered. It is not simply a place. When you hear the word medical home, it's not just a place, but it's the model for organizing that. They identified these 5 functions or attributes, all of which you'll see are the same terminology that I've talked about, that is really a part and parcel of all integrated care models: comprehensive care, patient-centered care, coordinated care, accessibility of services, and quality and safety. And the aim is to build better relationships between the patients and their clinical care teams. All right, so I mentioned that. The example that I have to share with you of this patient-centered medical home model, another acronym, the IBH model, or the Innovation in Behavioral Health model. It really extends the patient-centered medical home model to meet the needs of the people with moderate to severe behavioral health conditions, including psychiatric and substance use disorders. Early on, there was sometimes not a willingness to include the substance use disorders with this, or to exclude those with severe mental illness in any of these. This meets both of those because, as we know, there's often both things might be present. Recipients in this model receive whole person care in a behavioral health care setting. So here's the big thing. The previous 2 models, it was a primary care setting that had embedded behavioral health specialists in it. This is a behavioral healthcare setting. That behavioral healthcare setting is going to serve as the point of entry for patients to identify and secure further care. It was done this way because we knew that people with severe mental illness, if they have a connection to healthcare, it is more likely going to be for the behavioral healthcare needs. And it made sense to expand on that, use that reverse direction or bidirectional care, where we put primary care experts in the behavioral healthcare setting. Here's another difference. In this, the behavioral healthcare providers lead the care management team. It's not the primary care providers. They are a member of the team, but behavioral health providers lead it. And it addresses behavioral and physical health issues, as well as health-related social needs. I've already mentioned them: housing, food insecurity, and so on and so forth. So the additional screenings here would be opposite what the other two models have, which included screening for common mental health issues seen in primary care. These are screenings that would perhaps help to pick up and identify early on people that were at risk for physical healthcare things. So you might have screens that involve assessment for hypertension, for diabetes, for cardiovascular disease, etc., as well as social determinants of health, because we know that the impact of, someone who is unhoused, or someone who is not sure where their next meal is coming from, or someone who is at risk for ongoing physical violence where they're living or in the relationship in which they're involved in, has much worse outcomes unless those issues are addressed as well. So those screens are part and parcel there. So the next couple slides, I'm going to address a key aspect to this. Some of it is repeating, and I apologize for seeming perhaps redundant. The use of technology and integrated care. You really can't do, in my opinion, integrated behavioral health care well if it's not incorporating technology at a pretty high level. Doesn't mean it can't be done, but it's much more effective if you involve technology that can help. So I've already spoken a few times about this shared EMR. I think it's essential. The sharing of the data really enhances communication and encourages all the members of the team providing care for this individual to set it up for shared decision making, the individual patient and or their family members. I've also talked about the standardized screenings that can be done. You can also have ongoing patient monitoring, which sounds kind of very Orwellian and intrusive, but it's really monitoring perhaps for their physical health issues, monitoring blood pressure, or monitoring for those that might have COPD, monitoring their oxygen saturation levels. But it also could be used to monitor levels of depression, certainly risk for suicidality, things like that. The patient can be set up with his or her permission and agreement to complete fairly brief kinds of tools on a daily basis, which get entered into the electronic health record. And if there's any change or worsening of a symptom, there's an automatic notice sent to the behavioral health clinician if that's the issue that's presenting, or to the primary care clinician. And it really helps the patient become more involved, more engaged in their treatment, more self-aware of what's happening with them. There's also technology is focused a lot on clinical decision support tools. If you've got a patient with this and this and this and this, then do this, that type of thing. That also helps to promote patient engagement if you're working on it together with them or their family. And it also, I think, in my opinion, will definitely increase their ability to stick with the treatment plan. I think it's also important to keep in mind the age of the clients that you have and their basic comfort level with technology. If you have a younger population of younger clients who are certainly more than facile with technology through their phone, their tablets, whatever. These apps and the tools can really be helpful with follow-up care. There's also a number of digital mental health apps that can be used to reinforce skills that might be learned in the treatment sessions. For example, cognitive behavioral health ways to approach issues for this patient using CBT, using DBT. Those tools can be accessed on the apps, and they can reinforce the learning that was done at the therapy session. It also can be apps that provide additional sources of support for the individual that might not have been available. There's peer-to-peer apps, for example. When it's appropriate, those could be really helpful. And then finally, I had mentioned that we had, with COVID, started to use a lot more of telehealth or telepsychiatry approaches. We need to build on the success we had with that to continue with these models to increase access to care, especially if you have individuals who live in rural areas, people who struggle with disabilities that makes it hard for them to get to appointments, or those who face transportation issues. Any of those things could be helped with that. This is a graphic from the University of Utah, which talks about this issue of technology and integrated care. And it just kind of recaps what I'm not going to go through this in detail, but it recaps what I've already talked about, that there's levels of technology depending on what your organization is most comfortable with, what meets the needs of the populations you are trying to serve, and you can build up on this. You don't have to take all aspects of this. This in particular, University of Utah, obviously was something they were using to address the needs of college-age students. Makes sense that you would incorporate technology for that population. And the final topic I want to discuss in the last few minutes we have is issues around the behavioral health workforce and integrated behavioral health care. Things always, in theory, sound good, like, oh yeah, that would be nice to do it, but what is this going to mean to the people that are already out there working, boots on the ground, the current clinicians? What does it mean for the preparation of future providers? What does it mean for our organization? And what does it mean for the patients that we serve? So here's just a couple quick thoughts I wanted to share with you. When you think about it for the current clinicians, there's really some major paradigm shifts, and maybe some of your clinicians have already done this shift themselves. But with behavioral health clinicians, we've traditionally had a very purely clinical approach, kind of one-on-one. The expert meets with the patient, does the assessment, comes up with a diagnosis, works with the patient on a plan of care, sets up the follow-up appointments, things like that. In integrated behavioral health care, there's also a commitment to including much more community level interventions. So you remember I mentioned the incorporation of social determinants of health screens. Those types of issues don't necessarily fall to the behavioral health clinician to take care of, but they do fall to them to know who to reach out to help your patient with that issue, with their lack of housing, with their food insecurity, with their risk for domestic violence incidents, those kinds of things. So you have to be able to identify additional community-based resources and have a relationship set up with them where you can continue in an ongoing way working with them. And I would also say that behavioral health clinicians really need to understand the value as well as the appropriateness of digital mental health strategies, things that I'd mentioned before on the technology side. In terms of future providers, this is near and dear to my heart because this is what I tried to address. We who prepare the future providers in academia, we need to be able to integrate this content on integrated behavioral health care in all levels of education. For nursing, it's in pre-licensure programs as well as graduate programs. My favorite thing is to incorporate simulation-based learning to develop skills in multidisciplinary teamwork. If you're fortunate enough to be in an academic setting where you have a medical school, a nursing school, a medical school, a social work school, and a pharmacy school, that's a great opportunity to develop these simulations. Also presents challenges in terms of scheduling, but it's great. But even in a school that's a bit smaller, like Fairfield University, I put the family nurse practitioner students together with the psych nurse practitioner students, and although they shared some early coursework, this was later on in their program when they were already in clinical settings or about to step in, and this allowed them to understand far more what the other person's role was really about and how best to communicate with that person and what you could ask that person to help with and how successful it might be. For organizations, there's a number of tools you can use to decide if your organization is ready to move to this integrated behavioral health care. There's one called the IPAT, but there are others, and it assesses for all staff openness to operating under this different model of care. And it's not just clinical staff, it's administrative staff, it's financial staff, etc. All of them need to be on board in order for this integration to happen successfully. It also might help if you identify some potential champions, people who are already there on staff, who are interested in this, who are willing to learn more about it, and are willing to lead the way to support the implementation. You can get more people to buy into it if you get people boots on the ground prepared to set it up. And then finally, for preparing patients and families, you really need to introduce this to the individuals, families, if it's appropriate, to help them understand what's going to be changing, if anything, and what won't be changing in the organization, as well as how those changes might affect them. Um, if you have patients or family members who might be able and appropriate to provide input into this process of how it would be designed and developed and implemented in your organization, I would suggest that that's probably good people to get involved. And then final thoughts, we have a current healthcare system. I don't think I need to go over the details of this. We know that the system, the way it's working now, is broken. We're not able to meet these hugely burgeoning needs of mental health care across the country. Integrated behavioral health care does present some options for expanding our skills and our resources. And I'm going to give a plug here again because it's Nurses Week. Given that nurses have this background in holistic assessment and care, as well as the very high levels of trust that patients have in nurses, that they may be well prepared to lead those in putting these systems of care in place. We'll see if that happens. And that is the end of my thing. I'm going to stop sharing the slides. And I think we're at a point where we could have questions if people know. Hopefully I got it done in time, right?
You did, Dr. Shea. That was so beautiful. So much information there, and you are such an expert with these models. It's tremendous. We have some questions in the chat, and I'll get to those in just a moment. And so everyone out there, please, this is your opportunity to go ahead and put some questions, anything that you're thinking of in the Q&A box, and we will get to those. Dr. Shea, I had a lot of experience with integrated models through historically through the VA, and particularly in a panel, a group of patients with SMI, psychotic disorders, and I was kind of wondering about in various settings, kind of the presence of groups of various group therapies ongoing and who tends to run those, as well as also in your experience, kind of the role of a psychologist in these programs that you've seen. So those are the couple of questions that were coming to my mind
Sure.
as I'm dated on my information on the
Yep.
models.
Well, and it's evolved over the years. And I do think, and this is not necessarily direct from the literature, but it's in my experience, systems need to be developed in a way that really best that the people running that system thinks will best meet the needs of the people you're serving. And that can vary, from an inner city mental health clinic to kind of a more suburban setting that just is there's just a difference in the population you might serve and who you're trying to use this to meet the needs of. So when you talk about folks that are served through the VA who have severe mental illness, SMI, particularly the psychotic disorders, the answer, I believe the question partly was, was there a role for groups in these? And the answer is absolutely. Absolutely. Whatever the care team says is the plan of care worked out together with the patient. It should definitely include access, if needed, to both individual therapy, group therapy, family therapy, any of those sorts of things, as well as, well, and this falls under groups, but not the traditional psychotherapy groups, groups that might be more focused on how to manage your medical illness. So, how to better manage your diabetes, how to manage your nutritional status. If you're someone on antipsychotics who have put on significant weight and are now in a pre diabetic or perhaps already diagnosed with diabetes, those are things that we already saw happening for a long time now, unfortunately, in the mental health care settings that I've worked, but also in an integrated care model, you've got access quickly to the primary care people that can respond, rather than say to your patient, well, go see Dr. So-and-so this week, and they may follow up with an appointment, they may not. You've got someone that can kind of quickly look at the record, give some recommendations, decide if they need to see that person virtually today or in person tomorrow, whatever. So it's an access issue in that system. But in terms of the role of a psychologist, it would depend on what their interests were. So are they more interested in being on that, say, that primary care team where they do the quick evaluations of someone that's initially, it's the first time they've been referred, they do the evaluation, they work out the plan of care, that type of thing? Or would they rather stay as one of the providers doing the ongoing care in a group or an individual? So I don't think any doors are closed. Um, to do it, and there are a number of articles that talk about you can have very small, these models can be put in place for a very small number of patients, or it can be put for a very large number of patients. Obviously, the more patients you have in the system, the greater the variety of needs, and therefore the more opportunities for psychologists, social workers, counselors, whatever, marriage and family therapists might take in that role. I don't know if that helps or not.
Yeah, so much. I should also say that Dr. Khan had warned you and I prior to our start that she might get pulled away because there's some stuff going on in her role. So, um, and so I know she would have told you a tremendous job and is so honored here. And hopefully she'll make it back, but we'll see. We have a question here. What is your view on FNP's return to school for PMH certifications? As an educator and leader, what's your view on future NP education programs designs to integrate behavioral health care and produce NPs equipped for dual board certification from a current PMHNP student?
Okay, so this is a
Yeah.
this is a question that has multiple layers. And again, this is based on my personal experience and preference, but you also need to keep in mind when you're working with graduate students running graduate programs, whether it be FNP, psych mental health NP, you are also subject to accreditation standards. You need to be able to demonstrate that the students who are being given the degree that involves all of the coursework, including clinical, needs to meet the expectations that allow that student to become eligible to take the certification exam when they finish. So, that being said, um, family nurse practitioners have very significant coursework and then clinical that is focused on the FNP role and is there's no way that that could simply integrate mental health. I mean, you can certainly speak to them about commonly diagnosed conditions in primary care and prepare them that way and do those simulations that I mentioned, but they cannot become mental health care providers. What they are is FNPs who have an appreciation for how to do some initial assessment, diagnosis, perhaps early treatment, but they need to be able to refer on. They need to know when to refer. Okay. So the Psych NP, on the other hand, that program has its own requirements for coursework and clinical hours. And a student who's in a program, a combined program, again, my take on it, my opinion of this is that they have to meet both of them, which is a substantial number of hours. And students don't always want to be told they have to do both, but they do. So as a result, we at Fairfield actually had a fair number of family nurse practitioners who would come back to us, whether they were our grads or graduated from another FNP program, who would come to us and fulfill the psych mental health nurse practitioner curriculum demands to get certified in that as well. If they do that, that's fine. They can take on in their role, they could take on both aspects of the FNP and the psych mental health NP role. Um, it sometimes is overwhelming. So I would see all these students at one point to decide on admission, and I would want to be very clear with them what the demands are going to be. But it made sense when they described what their practice was like and why they needed to get this. We actually also had a couple of nurse midwives who came back and decided they want to become psych NPs as well. They weren't going to stop being midwives, but they saw in their practice the extreme need for them to have skills beyond what they were given in their basic program because there's not enough of us, any mental health care provider, to meet the needs that are out there. So again, I don't know if that totally meets the answer, but that's what I would say.
Welcome back. Thank you. Thank you. Welcome back, Dr. Khan.
Yes.
Hi.
Thank you so much, Dr. Shea. Wow, this presentation is just simply incredible. You
Thank
know,
you.
one of the things that I'm hearing a lot from our nurses, not just here, but nurses throughout Connecticut, due to my involvement with advocacy work, is our role. What is our role as it relates to advocacy? And what strategies can we employ, or what recommendations would you make, especially during Nursing Week? We're going to have nurses at the Capitol on May 21st. What could they do as it relates to promoting the health of our patients, and and what could we do as a group
Sure,
to move forward advocacy work?
sure. And I will start by saying what I'll speak of is related to nurses because it's Nurses Week and that's what I am. But it certainly applies, I would say, to any physicians, even psychologists, social workers for sure, and counselors, any of us in this field. It's part of your practice, in my opinion, to become an advocate for your patients, whatever that might mean. And it takes, for different people, it takes different directions from the person who is really intrigued by the policy/political system and decides that they want to become involved at that high level, bringing their experience and their knowledge to bear on policies that need to be changed, need to be addressed, new laws that need to be passed, protections, things like that. That's at the one extreme there. But back in the basic direct care roles that you might have in a hospital setting, in a clinic setting, you would be doing advocacy if you're aware, first of all, that and are gathering information about your patient's needs in the area of, like I was discussing before, housing, or if they're facing domestic violence risks, that type of thing, to be able to work with them to reach out to the supports in the community. We're obviously mandated reporters as well, so there's that aspect of the legality of it. But just in terms of boots on the ground, you have a patient in front of you who presents with these. You're not just saying, well, you need to get out of that situation because it's making you feel more depressed. None of us, I don't think, would leave it at that and, try to address and treat depression without also being aware that this person needs some additional resources and supports. So to have those lined up and ready to do within your smaller system, maybe it's asking them to move to this more integrated healthcare approach that will address the needs that you don't think are well addressed in your current system. So working with administration to tweak the model of care that you're doing to represent nursing on that, or to represent your patient in meeting those needs, is important, and going up from there. So it really, I tend to be a little bit of a policy junkie, and I love the opportunities to meet directly with either in the state or the federal legislatures to say, hey, this is happening and this needs to be addressed and this is why, type of thing. I've gotten really well trained, educated on how you make that kind of a pitch, contacting your own representatives on issues that you're aware of, whether it's a phone call or an email, should also be part of the role of any of us as mental health providers.
Thank you so much. So important. There's a question here. Is it okay for RNs with some level of behavioral health training to serve as the care manager?
I assume that they're talking about the healthcare, the psychiatric healthcare provider role that was
Yeah.
mentioned.
Mhm.
I would say, again, somewhat depends on the organization and the particular population that it addresses. Um, my druthers would be that it would be someone with a greater background. It could be a nurse, because a lot of nurses come back to get their nursing education after having gotten something else. So maybe they have an undergraduate degree in psychology and come back for it. My daughter did that too. So they have a background in it or something similar. That would be a little bit better. But it would be best if they could have experience in the field of psych mental health nursing, in my opinion, to be able to fulfill that role to the best that it could be. Reality is such that the organization may not be able to find someone like that to take that role. So you might have to kind of go with someone who has some additional education, preparation, and hopefully they can fulfill that because that has the consultant psychiatrist or psych NP at the same time.
Yeah, thank you so much. We also have a question here. In Connecticut, where can we access such integrated, coordinated, and collaborative care?
I assume accessing as you would be the patient or you're speaking as the patient, where can we go? Um, I mentioned CHC Incorporated. This is not, I don't work for them. I'm not paid by them, but I collaborated with them for opportunities for our students. And I know that CHC Incorporated has a number of clinics throughout the state, all of which follow an integrated care model where they're co-located. They are and they're integrated. They're much more than co-located. They are there together. They share office space. They have share electronic health records, all those things that I spoke of to get it. You could look for that. But I also know of other clinics that have maybe a little bit lesser, but some version of it. I worked with Southwest Community Health Center in Bridgeport, who also had a level of integration that didn't quite meet that they shared office space, but they might be co-located, and they did work well together when there was shared concerns about physical as well as mental health issues. And there are more. Inpatient, I know that the Connecticut Children's Hospital has a medical psychiatric integrated care unit. Um, if services are at that needed are at that level of care for both medical and psychiatric. So it's really a matter of looking up the places that are available to you. All of us are pretty much subject to what's covered by our insurance, or whether the place themselves accepts, say, Medicare or Medicaid. Um, but within that framework, do your homework by looking it up, and they will often have statements about whether they've got some level of integrated care. It's not unheard of now by most places. It's done better in some places than others. Speak to people who might have had similar issues that you've had. See if they found a place that offers that too. I guess that would be a suggestion.
Great. We have, let's see, 3 minutes left. So why don't I uh, send you off with a comment here. It says from a fellow policy lover, uh, from Tara Reed. Thank you for a wonderful presentation and for representing my alma mater, Fusan, with such excellence. Your insights were both inspiring and impactful, and it was a privilege to learn from you during this special week celebrating nurses. Tara, thank you so much. And
Thank you.
Dr. Shea, thank you so much for being
My
here with
pleasure.
us and agreeing long ago as we anticipated Nurses Week that we wanted to make this a special presentation. So thank you.
I hope it was experienced by
Yeah.
most in that
Dr.
way.
Khan,
It was certainly offered in that
Dr. Khan, I
vein.
don't know if you had any closing remarks.
No, just again, a thank you to Silver Hill Hospital for being interested in putting something like this together. Putting something together that very specifically involves not just nursing, but involves nursing at its most fundamental levels, and recognizing that this is while it's been around for 50 years, it is more and more developing into a legitimate approach to meeting the needs of many. And hopefully it will help people to think about their own organization and hearing it. So I appreciate Silver Hill putting it out there. And thank you to Dr. Khan too, and Laura and Ann.
Thank you. Thank you so much. Thank you everybody for being here with us, and we will see you next time for Internet Addiction. Uh, talk to
Thank
you.
you,
See you
everyone.
then.